and I will pass it. I can't see who else is here. Terrell, I know you're here.
Thank you, Wanda. My name is Terrell Gleason. I'm he, him, and Mister. I'm with Advocacy House in Greensboro, North Carolina. Thank you.
And last but not least,
I'm gonna pass it to. Yeah.
Hi, everyone. This is Dominique Johnson. I'm in Greensboro, North Carolina. I'm with Advocacy House, and the pronouns are he, him, and his. Thank you.
Thank you all for introducing yourselves. And I know Devin went ahead and introduced himself, and that was going to be part of our question lineup. So, Michelle, would you mind introducing yourself?
I'm Michelle Goyo, she, her, and I'm a Hep C bridge counselor with a small nonprofit called CareReach, and I'm based here in Asheville.
Okay, well, thank you so much. So our first question real quick, Devin, we'll start with Devin, then we'll work over to Michelle. Would you mind telling us more about the organization that you're with and the work that you do?
Yes, of course. And just to reiterate, my name is Devin Whitford, he, him pronouns, and I'm with the Western North Carolina AIDS Project, often known as WNCAP. So WNCAP, we do a lot. We serve 18 counties in Western North Carolina. So essentially from Cleveland County all the way up to the border of Tennessee. And we've been established in Asheville, and also we have offices in Shelby and Franklin, North Carolina. So we do a lot at WNCAP. So we're an HIV service organization that's been established since the later 80s, on the belief that all people that are entitled to equal access to healthcare. So in my department, we conduct testing and education outreach events in all 18 counties in Western North Carolina. So whether it's a church organization, outreach events, detox facility, inpatient treatment facility, we go do what we call an HIV 101. We talk about the basics, the 5 bodily fluids to transmit HIV. We talk about hepatitis A, B, and C, and a little bit about some STIs. Also, we do free testing for HIV, hepatitis C, and syphilis. So last year alone, so we're talking about 2019, we conducted 2,381 HIV, Hep C, and syphilis tests. And out of those, for hepatitis C, we had a 13% positive rate for hepatitis C. It's a lot.
That is a lot.
It's a lot. So in the past, I don't want to get too deep because I'm sure we're going to cover this later on. But in the past, we're like, you're positive for Hep C, good luck. But it's not like that anymore. We have a pharmacy services program to where we can immediately hook that individual up with a referral and care and treatment. So let me grab out my notes here. So last year alone, our pharmacy services program provided approximately $93,000 in out-of-pocket expenses. So that's including PEP, PrEP, and hepatitis C treatment. Because the biggest barrier I see is people just don't know where to go for treatment. And I'll kind of leave it at that for now. We can talk about it more later. But we do condom outreach. I always like to say we toss out condoms like it's like crazy. We really do. Last year alone, we distributed around 160,000 condoms out in the community. But it's certainly not enough. I wish I could say more, but I think I'm going to be talking too much. And I'm sure we'll cover more questions later on.
That we will, and that was perfect. So thank you. Michelle, could you tell us more about the organization you work with and the work that you do?
Sure. Michelle, she, her. And so I work for a small nonprofit called CareReach. We're about a year into existence. However, we are a spin-off of what was a long-term nonprofit called Community Care of Western North Carolina. They did primarily Medicaid case management. And then with the changes that have been happening with the state with Medicaid transformation, the majority of the organization joined our statewide network. So we had these small grant-funded programs that spun off. So we have Hep C bridge counseling in Buncombe County, and then we also have a couple programs in McDowell County that serve uninsured folks, and also just had 4 peer support specialists join us in McDowell County, working with individuals with substance use disorders. And we also have Sarah Hensley, who's in McDowell, and she is a peer support specialist, one of the ambassadors for change, and with lived experience with Hep C. So what I do as a bridge counselor, the position is actually fairly new. Going into the 3rd year of the position, it was originally funded by the state. It was 1-year funding. And then the county, the last 2 years, picked up the funding to continue this position. So I take referrals primarily from Buncombe for individuals who have been diagnosed with chronic Hep C. The referrals can come from anywhere: the health department, the hospital, substance use disorder treatment providers. WNCAP has sent over a couple referrals when they've had individuals who really just needed some additional support in terms of going through the treatment process. But also receive referrals from individuals outside Buncombe County. And we are very fortunate that we actually have a pretty rich network here in the western part of the state of bridge counselors and individuals who are coordinating care for Hep C at their respective practice. So we do a lot of collaboration to make sure individuals kind of get linked to care. And then if it's somebody outside of our kind of the western part of the state, then we help look around for treatment for them. So, and I don't have numbers. I thought about that, but I will say, kind of when I do my quarterly reporting, my caseload runs anywhere from 80 to 100 of individuals that are in some part of that care cascade, whether I'm trying to engage them in care, or if they've fallen out of care, or they need to get in for that final lab work. So it's kind of where my numbers run.
Awesome. Okay. Well, thank you both so much for answering that question and giving us some more insight into the work that you do. We're about to get into the heavy meat of the questions. Excuse me. I'm sorry. I'm also feeling a little down today, as Sherry might have mentioned.
Sorry.
So to get started, you both talked a lot about seeing things in Hep C care that are needed, such as having high numbers in testing or seeing people need an intersectional amount of needs for services. So what do you believe is missing from hepatitis C education for the general public from where you stand, be it with harm reduction, testing, finding providers? And I'll hand that question off to Devin.
Thank you, appreciate it. So as far as education, I feel like myself and my team are going out to Franklin, Robbinsville, like far off places. And the biggest thing I see is a lack of education. We'll get into syringe exchange programs here in a second, but I can't tell you how many people that I talk to on a day-to-day basis that think they can give Hep C to themselves, meaning that if they use their own syringe over and over again, they think they can give themselves Hep C. It's very common, and so a lot of people think that. So, I just kind of pose a basic question is, where's the infected blood coming from? So it's just a basic education. And we just have to realize that a lot of people have Hep C, and there shouldn't be a stigma around it. It's just part of the world we live in Western North Carolina and the United States in general. And as far as the treatment, a lot of people think the treatment is impossible. Treatment is not impossible. Treatment is definitely accessible. And, there's kind of a lack of, going back to the lack of education as far as the interferon medication that was used years and years ago. That's not the case anymore. In the past, it took anywhere from 24 to 48 weeks to get treatment. Now we have it down to 8 weeks. And there's very, very, very few side effects for the medication. And some people just don't want to go through that type of pain. And it's not like that anymore. And another thing is, it's a lot more cost effective. I've heard crazy numbers that anywhere from $30,000 to $50,000 out of pocket for Hep C treatment. That's ridiculous. And it's not that case anymore. There's tons and tons of patient assistance programs out there for folks to receive treatment, whether you're talking to Michelle, the great hepatitis C bridge counselors that we have, or a lot of the EPQ-HCs that we have in our community. There's definitely tons of treatment options out there. Another misconception that I see is for folks that do have Hep C. Maybe they have kids in their life. Maybe mom's shaving her legs, or dad's shaving his beard. Maybe nick your neck or nick your leg and show, hey, this is why you don't mess with mommy and daddy's stuff, because any type of microscopic levels of blood can transmit Hep C. All right. And when we go to syringe exchange programs, we're talking about a 10-cent needle. That's really what it comes down to, a 10-cent needle for people to get to avoid transmission of HIV and hepatitis C. So our harm reduction program here at WNCAP has been busier than ever, and very thankful for that, because with the way things are now, people do have access to that type of care. So, but yeah, and another thing is 10 to 30% of people will naturally clear the virus on their own. Don't know why. I like to say good luck and a very good immune system. But it's always good to have that just community level information, what I call one-on-one information. And that goes a long way.
Thank you for that answer. Yeah, there is a lot of information out there, and some of it is a bit outdated. So it is nice to have access to up-to-date information. So I will ask the same question to Michelle. What do you believe is missing from hepatitis C education for the general public? And again, that can be from harm reduction, it could be for testing, finding providers.
So it dawns on me, I kind of went off about what our organization didn't really explain what it is I do, but I'm a linkage to care coordinator essentially. So anyone who's diagnosed with chronic Hep C, my role is to make sure they get connected to medical care. And I think, Devin really touched on about the education piece of it, that I think when I get a referral and kind of talk with the person, get some information, what support they might need. It's also, I ask about how they think they might be exposed, and do this in a really non-judgmental manner, because I want to provide them education, but also want to figure out what their risk factors are to see about the risk of reinfection. And one of the things, it's again, people are really surprised about Hep C, like where they may have, for individuals who may not have been infected through drug use, IV use, there's a lot of shame and stigma, but people realize it may have been the tattoo that they got from their Aunt Susie 20 years ago. So just really that education and trying to decrease that shame and stigma around it. And also we're really, this can be treated really easily in primary care, and we really need a lot more primary care providers out there providing the treatment. It doesn't need to be done in a specialist office anymore. We need individuals who are out there providing the treatment in a non-judgmental manner, treating people who are actively using. The research bears out that even if somebody has an active substance use disorder, whatever that might be, that their rates of success in treatment are almost as high as individuals who are not using. So really kind of part of my role is to also try and engage primary care providers to encourage them to go through what's called the CHAMP program. It's the Carolina Hepatitis Academic Mentorship Program. It's through Duke and UNC, and it's they're now doing it in virtual format to really get primary care providers comfortable with treating. But I think what's also missing is And Devin, again, they're out there much more in the community on the ground doing the education, but just looking at other groups, kind of non-English speaking or minority groups, really getting the education out there to get them engaged in care. And I also just want to say, you know, here in Buncombe County, we're very fortunate in terms of the providers that we have. But what I did in terms of thinking about today is I actually reached out to the other bridge counselors. We've got somebody who covers the 8 Western counties and McDowell and Madison, and just really got there, and Henderson, Transylvania, Polk, Rutherford, and really asked for their input because they are in more rural areas. And of course, the themes were very similar. So just wanted to kind of share that I kind of some, what's the word? Anyway, some collaborative information, I guess is what I'm trying to say.
Yes, thank you. The collaborative information is always really helpful, especially when people are working in rural areas that may not necessarily be Western. They're out in the eastern portion of the state, or there may actually be some central counties that are rather rural. I mean, I'm in Johnson County. We're not necessarily rural, but it's out there. So you both talked a bit about Hep C treatment too, about how Hep C treatment has changed over the years, finding providers. I'm so happy that you mentioned the CHAMPS program. It is a really effective program, and I wish more people knew about it. But in terms of having these treatment options, why is it important for people to seek treatment for hepatitis C? And again, we'll start with Devin.
Thank you again. It's a very simple answer. The earlier that an individual gets the treatment, the better off that they are. I mean, of course, I've talked to individuals that known they've been positive for quite some time. But the thing about hepatitis C is, you know, the symptoms kind of come and go over a very, very, very long period of time. And also the treatment regimen will be a lot more efficient and a lot faster too, the earlier that the individual gets that treatment. And also there are some subtle symptoms that I'm sure Michelle can allude to that the biggest symptom that I see in individuals is people feeling really fatigued. And when I do like when I'm testing somebody, I kind of ask like, how are you feeling? It's like, I don't know, man, I just feel tired for no reason whatsoever. And that's the more common symptoms that I see in individuals. And in general, you'll feel so much better. Your body will, your mind will feel so much fresher. And also it'll give your time for your liver to kind of restore itself to its not original form, but to kind of revive itself. And when we go out and do education sessions, we like to say there's 3 things that we can do on a day-to-day basis to kind of refresh our liver. 1, either cease or reduce all alcohol intake, then of course you want some water. 2, you want to cease fatty foods that may contain some grease in it. So, insert some healthy leafy greens into our diet. Okay. And in 3, I say exercise. And of course, exercise means a lot of different things to a lot of different people. For me, I like to take my dog out for a walk, so it could mean a lot of different things. Just being up and being active will go a long way into kind of how your body feels on a day-to-day basis, especially when you're living with hepatitis C. But yeah, that's all I have for that.
That was an excellent point about liver health. I know Christina said in the chat that Hep C is a silent killer, and it really is. So having that understanding of your liver health as well as treating Hep C is really important. So thank you for that. Michelle, why do you think that treating Hep C or people should seek treatment for Hep C is important?
Again, because, for a lot of people, they don't have the symptoms, or maybe they start not feeling so great, not soon after exposure, and think, I have a cold, maybe I have the flu, and they don't get tested at that time. But again, they can go years and years without having any symptoms or bothersome symptoms, and that Hep C virus is slowly doing damage to that liver. And certainly if they are alcohol, really kind of between alcohol and Hep C together, that just is kind of throwing, fuel on the fire. But the medications are well above 90% effective for most people. In terms of the individuals, and I'd say, I don't have the facts and figures, but there's been very few people who have gone through the treatment who haven't been cured. And those are individuals who, didn't take the medication as prescribed, or were ended up reinfecting. And people don't realize that the medication's 8 to 12 weeks, 1 to 3 pills a day, and have very few side effects. And there are options in terms of covering the cost of care. And so it's really, some of the doctors I work with said, in terms of the primary care doctors, in terms of the chronic conditions or the potentially fatal conditions that they work with in their practice, like, this is the easiest, best one, because they can say you're cured. And the treatment is out there, and we just need to get people engaged in it.
Thank you for that. That is, it's really impactful to know, to say, you're cured. Like, I know this is probably something a lot of people have wanted to hear for a long time for a variety of illnesses. So that is a very empowering factor.
I was going to say, sometimes if the doctor's office can't get in touch with the client, I get to share those results, and that's the most exciting, that's an exciting part of my job, but also it's such a relief, and people really can't believe to hear those words, you're cured. So it's really satisfying that people are getting the care and getting cured.
And just letting folks know there is a treatment. Yeah, I mean, you'll be astonished of, people in the general public that are unaware that there is, in fact, a treatment for hepatitis C, and a very effective treatment.
That is no longer taking you six to 8 months. So yes. And you both brought up a really interesting point, actually. You work both with patients and you both work with providers. So there's connection to care and communication with the patients. And so from your perspective where you work, what are the 3 biggest obstacles for providers that you've seen since the start of COVID-19, since COVID-19 has created some unprecedented pressures? And I'll start with Devin, sorry.
Just making sure. So I would say, without a doubt, having individuals do more, having their visits done over Zoom or online. And especially in Western North Carolina, internet access is not guaranteed. You may be somewhere off in the boonies, and you may have internet access, but not reliable internet access. And that's just one of the problems. Just having internet access in general is also a barrier for a lot of folks. And I'll kind of say this over and over again, and I think we all agree that people who use drugs are often the most stigmatized people in our communities. And especially early on in the pandemic, there was a lot of misinformation about COVID. And I think that has kind of pushed further the stigma of people using drugs and people that do have Hep C. And it could be a barrier. It is a barrier for people that want to access treatment for hepatitis C. Yes, and also people, especially in Asheville, people that are facing and experience being homeless, and being able to make an appointment, being able to get in contact with their healthcare provider. Yeah, I can't really say too much more about that. Also, I'm kind of crossing over to a different question probably, but a lot of these medications that providers have people take requires food. And if a person experiencing homelessness and doesn't have proper access to food, well, there's not a really good point for the medication then, right? Because really a pack of crackers isn't really a substantial amount of food. and also people having access to cars and be able to get to their appointments. That's a major factor as well.
Thank you for bringing those up. And actually, I did see that Raymond commented in the chat. Transportation is
Mhm.
also an obstacle.
Yes.
The food comment really threw me. It's not even. It's one of those things that you don't really think about. Like it's totally a thing. Like, wow, you got the treatment, but you need other things to make the treatment effective.
Yeah, definitely.
So I'll ask that same question to Michelle because I'm excited to hear what she has to say too. So what are the biggest obstacles for providers that you've seen since the start of COVID-19?
Well, I know you said you're excited. I don't have anything more exciting to say, but I think the technology piece of it, especially in a rural area, or even if people have cell signal, do they have the data plans? Do they know how to use the technology? Are they there at the time of the appointment? I think that the providers have done a great job really quickly having to adapt to what kind of we all adapted to pretty quickly. But it's a technology, it's the billing, it's the schedule. And I just have to say the providers have done a great job. And on the flip side, I think we're going to see a lot more telehealth continue in the future, which for clients who don't have transportation, it's actually a huge benefit. Also, our health departments, where a lot of the testing was done, they're just overwhelmed. And it looks like at this point in time, we'll continue to be overwhelmed with COVID testing. And, so I don't know how much people are getting in for testing. I don't know if test results are getting conveyed. Right now, they've got such a focus on COVID. And then for providers, well, this is more for your next question, but I talked to Rachel, who's in Madison County, and she actually saw that this has not been a big barrier for providers, that the telehealth has actually worked out really well in their rural area. So it's good to see the technology's not necessarily been a barrier for all providers.
Oh, thank you for that. Yeah, the technology piece is definitely something I've been hearing a lot about, especially in the rural areas, like you mentioned, that have spotty internet or spotty Wi-Fi access to these things. Having stores to go and buy a laptop or a computer, like those things are limited out there. So thank you for bringing that up.
Deshay, could I say one more thing?
Of course.
So, and if you think of kind of provider as the non-medical provider, but maybe that ancillary services, like with WinCap with testing or syringe access, or we just haven't really been able to go out and do our outreach events or testing events, kind of where people would gather, where we could provide the information. And I think that's been a loss in terms of getting into the community, ability to really kind of go to those events and, provide the information.
Yes, just to add on, since we do all the education and outreach as much as we can, we've only been able to go back to around 25% of our normal routine as far as our outreach events, education sessions, all those types of places. And it's been really hard on us, to be honest with you.
Yeah, I do remember doing some direct practice, and those outreach events are really when you start to see the community come together, and that's really when you can make those connections and get that care cascade going, like Michelle mentioned. So the follow-up question to that, for the side of the providers, what are some of the biggest obstacles that you've seen for patients? I know we've talked a bit about transportation and access to food. Edith Stitwana made a comment about food disparity being much bigger than expected. And I could definitely see that being a thing. So Devin, what do you see as the three big obstacles for patients since the start of COVID-19?
Great question. I'll start with a little story. So I was at a treatment facility in Black Mountain, North Carolina, and we were talking about hepatitis C, and the individual I was talking to had hepatitis C for a very, very long time. And I was like, so have you ever thought about treatment, trying to engage the individual and see if they would be interested in treatment? And she said yes. Um, I saw a provider, and he told me that I had to be abstinent of all substance, of all everything for 6 months. So she said, okay. And I did it. And that same individual comes back 6 months later, and the provider says, oh, well, things have changed and now it has to be a year. And she flat out said, screw it. Excuse my language, but screw it. Like, I'm over it. And, the recommendation is treat the individual. Simply put, treat the person. And so that's kind of one barrier there that I've seen is a lot of our fairly qualified health agency around town have been great, very accepting, but there's been a few providers here and there that give individuals some barriers like that. So as far as some other things, kind of what I've hit on before, people know they have it and just hear all the time that it's so unattainable because it's so expensive and I could never afford that. I can never afford it, which is totally understandable. But kind of what Michelle alluded to earlier, people, that's kind of why it's, hurts so much, because we just want to get out into the community and let people know that, yes, there is options. I just spoke to Amanda Wood, our pharmacy services program coordinator, and we've had a 100% success rate. So if an individual comes to us wanting to seek treatment, they're going to get treatment, regardless of finances, anything. It doesn't matter, because the recommendation is that we should treat everybody that has it. And I'm kind of going all over the place, so I apologize in advance. Something that I'm really, really passionate about. Just going through my notes here. But yes, so I can't say enough that we've been extremely limited by the way that we can go out and do testing and outreach. We've developed, most of our testing right now is in coordination with our syringe exchange program, which honestly has been busier than ever. Last year alone, we have distributed over around 11,000 overdose reversal kits, and that numbers continue to rise. And big shout out to our harm reduction team. I see you, Raymond. But yeah, so plenty of barriers. I apologize for going all over the place again, but I can't speak to that enough.
I really think that, especially with feeling like you're going all over the place, it really talks about how overlapping a lot of the barriers are and how common we see them. So same question to Michelle. What are some of the three biggest obstacles that you see for barriers for patients since COVID-19?
I would say, when we talked about the technology piece, but the reduced in-person services, so many things. There's, at least initially when we were all trying to navigate COVID world, reduced in-person services, people told to go online. Well, it's really hard to do applications over a smartphone, or if you don't have access to a computer, and for a while the libraries were closed, and not having kind of that person with you to help guide you through those applications for food stamps, whatever it might be. I'll go back to what Devin was saying around the food security. That's been huge. I know I had a lot of individuals on my caseload who were in the hospitality industry, lost their jobs. And in the 2.5 years I've been doing this, I have been going out and picking up food boxes and delivering food to individuals. And then housing instability. I don't know, kind of with the other part of the state, this area can be really expensive. People not having, there's been the rent protection programs, but losing your job and just, people kind of put Hep C treatment on the back burner because they were prioritizing their basic needs, food, housing, shelter, taking care of their kids who are now home from school. So, and then DMV, I get several people who are coming out of prison who need their IDs, and they need their IDs to get jobs, and they've got a felony background. They kind of already have that strike against them, getting into DMV to get their IDs. So it's more kind of been those social determinants of health that have just really kind of had to take priority for people versus their Hep C treatment. And then just people who are fearful to go in for their appointments if they actually have to go into the clinic. We have lots of people that have not come back for their final lab work, which will tell them they're cured out of fear of COVID. And I mean, that makes sense. I understand that.
Thank you for that. Yeah, I do see in the comments that Raymond mentioned that DMV appointments are hard to get at this time. I know I plan on taking a trip to Canada this past summer. And as soon as COVID started, I was like, oh, I don't have my passport. And the post office was like, well, you won't have it for another 18 months, honey. Look elsewhere. So I definitely get that. But you both touched on some pretty important things about like how there are a lot of basic needs that need to be met in order for people to be able to access treatment. Really going back to that Maslow hierarchy of needs like safety, food, shelter. So yes, thank you so much for touching on that. And we did have a follow-up question in the chat that I wanted to bring up real quick. And it's from Wanda. And it is anything done about the providers that Devin mentioned who put up or create any barriers? I'll let Devin go first. And then we'll head over to Michelle.
Can you repeat that question, please?
Yeah. So, what is being done for the providers that may be creating some of those barriers to care? It's like you mentioned with the abstinence. Yeah, that would be the question. And both you and Michelle could answer that if you're both comfortable.
Well, I don't really ask for like certain providers in our area. I give the individual the facts. I give them links to the centers of the disease in control, and just give them the facts of what the recommendations are. And I've seen it. A lot more people being better about kind of prescribing people Hep C treatment on demand, like when they actually need it. But I don't think there's much being done for certain providers.
Michelle, if you want to chime in.
So I think that's, for me, if I get individuals who've been referred to me who maybe tried treatment before and provider wasn't willing to treat, and I think that's maybe more of our specialist offices, then we look at different options. We just say, you know what, you can be treated. Let's find you another provider. And that's not necessarily an easy task, but I don't even try and get into that provider education. I don't think that's more of a doctor to doctor thing. So I'll let the doctors talk among themselves to do that. I just help them find a provider who will treat. So, and I actually want to go back to that last question about barriers for clients. Since the start of COVID, it's also been, of course, depression and substance use. And then a lot of things have moved to online, like Zoom meetings and that sort of thing. I think just, having access to those services and then having the motivation to kind of take care of your health. It's, we've all seen it with whether it's people we know, ourselves, our clients, that this has been a hard time.
Agreed. It's definitely taken a toll on mental health and probably pushed mental health care needs to the forefront, but how we address those is still questionable. And so another follow-up question to both of the other two follow-up questions is COVID-19 aside, I know we've talked about some other barriers to care, but are there any common or repeat barriers to care that you encounter? Or another way to think about that, is there anywhere in the cascade to care that you see people falling out due to a common barrier?
So I'll go first again. So one of the most common things I see is medical jargon like crazy, like things that I don't even understand. So, for example, I'll go to a treatment facility and during the testing process, and it's like, so have you ever been, have you ever tested reactive for Hep C before? And I'll get this very complicated answer from the individual, and they have no idea. I have no idea. They'll be like, well, I have the doctor said I may or may not have it. I have the antibodies. So just a lot of confusion in general about what's being said to that person, which is totally understandable. So we will go through the testing process again and kind of explain the difference between a blood test and an antibody test. And that this true, they may or may not have it. Like I said, there's probably anywhere from a 10 to 30% chance that it could clear their body. So that's kind of one barrier right there. Also, say it again, just have no idea where to go. Just think about it, right? We live in a very rural area in North Carolina. We're not even talking about Asheville. We're talking about even farther west than Asheville. You have Hep C. You've had it for a very long time. Don't show any immediate symptoms, and you would have no idea where to go. And if you do go to your healthcare provider, they're, for one, may have a lack of education on how to treat you, or kind of make it seem like it's impossible to be treated. Okay. And again, another story, I hate to bring up all these stories, but some providers won't treat you until so far into you've been positive for so long. They want your levels to get higher and higher until they'll be able to treat that individual. So I can go on and on about that, but in short, those are the common barriers I see.
Ooh, okay. Yeah, I can definitely relate to having to break down some medical jargon. I spend a little bit of time in the dictionary myself. And I've also heard the one about needing higher, I guess it's liver enzyme levels.
Yeah, enzyme levels, yeah.
But again, back to medical jargon being confusing. So
And-
what were you gonna say?
Yeah, just to add on to one point. So, there's only a handful of areas in Western North Carolina that have access to syringe exchange programs. We've got people from 4 counties and not 4 states and 32 counties, and people will pile up in a car and make a day trip just to come down here, just to access simple tools to keep our body safe. And it's I give a lot of credit to those individuals that are making that step to look after their body. But I kind of think about all the people that really don't have access to vehicles or transportation to get down to Asheville just to have access to silly needles, and it kind of drives me crazy sometimes.
10-cent needles, as you said earlier.
Yeah, exactly.
Same question for Michelle. What are some of those common, COVID-19 aside, those common barriers to care that you see, or barriers in the cascade of care?
Well, we talked about education, the importance of that, because there's so much misinformation about Hep C, its treatability, about being able to afford the treatment. But I would say overarching is transportation, absolutely a huge barrier. And we are really fortunate with CareReach that we had some money. It was a donor that gave some money and said, what is the best way you think you all can use this? And we designated that money to coordinate with Ride Health, which is a national transportation program. And we have it for Buncombe and Henderson County, and then in McDowell and Mitchell and Yancey, we contract with their existing transit services. And so Ride Health contracts with, here in Buncombe County, it's Uber, Caesar Family Services, and Pavone. And honestly, without that service, even here where we have the bus line, never mind those rural areas, being able to get people back and forth to medical appointments, to their court dates, to Social Security office. We really don't think we'd have as many people engaged in treatment and getting cured kind of as maybe as rapidly as we can do it without transportation. And we, you know, Buncombe County is not rural, but we have some rural pockets on the outside of the county. So when you have somebody who's living out there and who's not on the bus line, doesn't have a vehicle, maybe has a vehicle and no license, how are they supposed to get to treatment? So I would say transportation is huge. So.
Sorry, I keep forgetting that I'm muted. Okay, yeah, transportation. I would imagine that being a big barrier in a rural location. I currently am also going through the transportation struggle myself. But it's good to hear that programs like Ride Health are available. I wish we knew more about those programs, or we knew more about programs available in our areas. So our next question is, as you've been tackling these challenges and still providing care to your to patients, people in need, and still communicating with providers, what partnerships or strategies have proved to be the most helpful during the pandemic for you and your organization?
So for the Western North Carolina AIDS Project, even though our offices are still closed, our syringe exchange is fully operational. For one, we have kept the same hours. We don't put any restrictions on anybody. Seeking supplies, same staff. We try to keep, we're doing our best to keep things the same, okay? And as far as our testing abilities, we have a COVID screening tool to where a person can get a temperature check. And also we have a survey of questions that ensure the safety of that individual and also the staff that comes into the building. So we're kind of adapting as much as possible during these times. And also, even if we weren't in COVID times, we can't do this all by ourselves. It's impossible, right? So stay in contact with the local county health departments. Always try to keep a good relationship with them because they are under enormous stress and pressure right now. So whether it's our food banks, our community organizations, our local churches, just the little things, we try to keep more of a social media presence out since folks can't come into our office, just letting the community know at large that we're still there for them and we're still offering all of our services. And it's really frustrating, especially because the facilities we go to are condom outreach spots. A lot of them are closed down, some for good, actually. So we're doing our best to be supportive of the organizations that have supported us for so long. So whether it's giving them a social media post, little things like that to kind of make sure that everybody's involved in the process. That's all I got.
Just realized I wasn't muted. Okay, yeah, having those social media strategies I definitely feel like is really important, especially with everything being online and virtual right now. And having those relationships with the health department, it's like you mentioned, since they are overwhelmed, being able to have them to funnel the people to other services. That way they're not missing out. So same question for Michelle. What partnerships or strategies have proved to be most helpful during the pandemic for you?
So I was doing face-to-face intakes pre-COVID, and I'd either meet them at the health department or they'd come to my office. So our office shut down for a few months, but I have continued with the phone intakes, which actually it's a little hard because I've not met a lot of my clients, but it's been a little more efficient because when I call them, they have time to do the intake. We do it right then and there. So I've been able to engage them. It saves them the time and travel of meeting face-to-face. So it's actually had some good benefits. I've also used that time to do COVID education. You know, there's some strong feelings out there about people, whether they believe there's a virus or they should wear masks, but I just do some education. And then when I send the intake packets, I'm also sending additional information about food resources, COVID, mental health care. I have some individually wrapped masks that I'm sending out just to kind of make sure people are keeping themselves safe. So, and then with the partnerships, we've just adapted in terms of continuing our collaboration. And it's really getting hard with, we're all been on Zoom a lot, but just continuing those collaborations and just finding out how people are adapting to care, so that if I'm talking to a client about a provider, I can let the client know what to expect, whether it's a telehealth or what that'll look like, or, you'll need to wear a mask. So a lot of it's just shifted online, but there's also been some benefits too.
Can I add one more thing too?
Of course.
Thank you. Also, like, I think we've harped on the fact that transportation is a major barrier. And with these special partnerships that we developed with some of our local federally qualified health centers, we're able to actually deliver medications to individuals at their front door, and which is very awesome. I can't stress that enough. And also, it's packaged in a way that it's bubble wrapped, and to where you get like day by day, dose by dose, it's dosed out properly. So just a simple fact that people can get a home delivery service right there to their door, and 24/7 support for a lot of these things too, is very valuable. I can't stress that enough. It's like, I wish like some individuals would know like some of the, dirt roads in the far west regions of Western North Carolina, and having that service for some folks is literally a lifesaver. So just that home the service to where medications can be delivered on demand.
Medication delivery does actually sound very effective. And I've heard it done before. So I usually hear it with HIV treatment. So it's nice to hear that it can also be done with Hep C treatment. And thank you so much, Michelle, for talking about COVID education, because ambiguity can lead to anxiety, and that leads to a whole bunch of other things. So that educational piece on COVID-19, I think, is also really essential for helping relieve some of that anxiety. So last question before I get any questions for the audience, and then I need to pass it off to our wonderful executive director, Lee. He's got some information he wants to share with us, and I'm really excited for you all to hear about it. So that final question is, as agencies operating in other very rural parts of North Carolina, what advice can you offer other agencies and organizations?
I would say make friends, and make a lot of them. I'll explain. So it could be anything as talking to the health department director. It could be talking to a church leader, a community organizer, anything to where you're going to be entrenched in that community. That is probably the best thing that you could do. And talk to folks that have lived experiences, whether we're talking about HIV, injection drug use, hepatitis C. Talk to the folks that have lived experiences. And with those special bonds, we together make an intertwined network of it's a big, huge resource. That's what it is. It's a really big resource. And I've known people way out in Franklin that have resources, and they can refer people to me. So it kind of works both ways. So the more connections that we make as an organization, I'm kind of working with, or the folks at WNCAP and Michelle too, are working with a huge area. We're talking 18 counties, or however many counties we're talking about, just a really big area. So of course it's been hard over the past 6 months, but just making phone calls, having those Zoom calls. I'm not big into having meetings. I like to go out and do the work, but making those phone calls, sending the email, just letting folks that we're here, we're available, we're for you.
Yes, tap into that network. Michelle, did you have any advice for other agencies working in rural areas?
Just what Devin's saying about making friends and collaboration and getting to know who the partners are. Again, here in the western part of the state, even with the real rural areas, we have a monthly meeting. We have people who are doing the kind of bridge counseling work or coordinating care for their clients with Hep C in their practice. And it's a problem solving kind of idea exchange. And we just really good collaborative working relationships that have built over time. What would be on my wish list is a community health worker. I'm even pre-COVID really kind of stuck in the office with all the incoming referrals. I really wish we had somebody, a peer support specialist or a community health worker that can really get into the community and help find those individuals that are not engaged in care, who are just having a lot of barriers around transportation, housing. So that's on the wish list. And then I am also fortunate that I have access to provider EHRs, so I can have direct communication with the providers, and that's been a huge benefit. So if if people can get that access to EHRs, I think is a huge benefit.
Agreed. I do see a lot of need for community health workers, people who have the lived experience and know the trenches. They know the ins and outs of the trenches and the side streets that we don't know about, and they really have that connection. So yes, thank you both so much for answering all of our questions.
Thank you.
You've both been such great presenters, and I learned a lot of great information. I know I was looking down a lot, but I take a lot of notes. I think notes are really important. Oh yeah, come through notes. So real quick, we've got about a minute before I need to pass it over to Lee. Did anyone have any final questions they would like to ask our presenters before Lee talked about some really important Hep C and harm reduction policies? Swipe through. Okay, well, I don't see any hands and there's not much in the chat, so I'll go ahead and pass it off to Lee.
I think
Thank you.
Terrell has.
Oh, Terrell, did you have a question? There we go.
Just a real quick question. First of all, I'm Terrell in Greensboro with Advocacy House. And I was cured of hepatitis C in 2015. And it took, I was supposed to be in a study starting in 2012. It was really hard, because there was not a treatment. So with there being a treatment, having a cure, getting that message out there is really challenging. And back then, the treatment that I did, it was 10 pills a day. It was Verapac. I had lived with the hepatitis C for so long that I needed that particular product. And part of that was ribavirin. I mean, I took 10 pills a day for 3 months, no side effects, no issues. It was easy. I worked full time during it. But I think I heard Michelle say that it's now 2 or 3 pills a day, and which is great. Is part of that, is the ribavirin in that, or do you know if that is still part of the hepatitis C treatment?
So I don't know if that's part of the newer medications out there. There's 2 or 3 that they use as the kind of first line. Well, I know Mavyret and Epclusa, and I don't know kind of their chemical names. I don't know if ribavirin's part of that. There's also Vosevi that they use for people who weren't cured the first time or have more advanced liver disease. I don't know, yeah.
If you don't know, that's good, because it's telling me that it's probably not. And there was some problems with ribavirin, you know what I mean? So that's good to hear. Thank you very much, and thank you both for presenting excellent presentations. Thank you.
Thank you.
Thank you.
Thank you so much for the question, Terrell. I know those of us who are still trying to learn the names of the treatments are always appreciative to know more about treatment options. So as I mentioned earlier, I'll go ahead and pass it off to Lee so he can tell us more about some policies that are in our area.
Yeah, so I just thought, and as terms of wrapping up this conversation, I'd just share a couple thoughts on some of the sort of legislative landscape issues we're thinking about around hepatitis C and harm reduction headed into 2021. I think I noted a couple of this briefly this morning as well. a number of y'all were part of some efforts back in 2017 through HIV Speaks on Jones Street and some of our advocacy work to increase appropriations related to hepatitis in North Carolina. NCAIDS Action Network led the charge that year, and we did get an additional $600,000 appropriated from the General Assembly that went to the Division of Public Health to support hepatitis-related work, both to support testing and linkage to the cure. That appropriation was $600,000 in 2017, $600,000 in 2018. Half of it was made recurring, half of it was non-recurring. So that non-recurring portion we were not able to sustain in 2019, but the General Assembly has continued to fund that $300,000. So we, I think are really proud that that appropriation campaign in some ways built some lasting infrastructure long-term that's going to continue to allow, the state to have some dedicated funding for testing, which I think we all know how important that is. I do think, we tried in 2019 to get more funding. Obviously 2020, the budget landscape was just very strange due to COVID. But I think we will be back and make another ask of the General Assembly in 2021 to put additional funds toward hepatitis. Candidly, I think we felt that it's a strategic space for us to be in terms of appropriations. The HIV funding landscape is there's never enough funding for this public health work, but there is a massive federal program, right, funneling money into North Carolina through Ryan White, to fund HIV treatment and prevention. And there really is a gap when it comes to direct funding for the public health work around hepatitis. So know that I think that's going to be part of our community and our network's agenda next year, is, trying to get more funding. And candidly, with the legislature staying in Republican control, I think hepatitis is going to be, with this administration, I think it's an easier lift, right? It's something with the opioid epidemic and the attention brought to it. I think we have an easier time getting funding around hepatitis. We are concerned, and I know we're having another session on harm reduction this afternoon, but have seen some hints and signals that we might face a challenge to the syringe service law that was passed in 2016. There is a neighborhood group based in Buncombe County that has been frustrated by the syringe service law, that has publicly talked about trying to file legislation to amend that. I feel very confident the governor would veto that, and I feel very confident we would even have both Democratic and Republican support for keeping the law strong, but that doesn't mean we won't have to fight it. So, think about that. That will certainly be part of our agenda for HIV Speaks on Jones Street. And then also want to flag, I know we talked a little bit about sobriety requirements. The Medicaid program is moving forward with dropping the sobriety requirements for folks who are insured on Medicaid in North Carolina. We submitted comments in support of that policy change with the Center for Prevention Services in Charlotte and the Queen City Needle Exchange on Monday. We shared an image of those during our tweet chat yesterday, but actually haven't posted them publicly and have been meaning to do so. So we'll get that up on the blog and can send that out to folks as follow-up. We have every reason, I think, it is going to happen, but I think it's, something to lift up and celebrate and be excited about, that North Carolina's Medicaid program is dropping those requirements. So now that was super fast. I know, and we're at 1, but any quick questions or thoughts or comments from anybody about any of those pieces? Awesome. Well, yeah, so we're at 1 o'clock. We have a break now until 1:15. Do take your break, right? Get up and stretch. And I know, as we're rounding the end, the Zoom fatigue is real. So it's nice to, see a little bit of sunshine and take that breather. But yeah, we have our final set of breakout sessions happening at 1:15. And as I joked, I think at the start, we are going to release the official BPAS playlist during the closing session. It's just going to be a brief check-in, but that's your incentive to stick with us through the rest of the afternoon and make it to that closeout session at 2:35, I think it is. So Yeah,
Hi.
Michelle, you want to say something? Yeah.
One quick thing. If anyone's interested, and I can send the link to Deshay, we have in the western part of the state an access to care inventory, and it talks about our syringe access programs and our Hep C treatment providers for the counties, mostly pretty much all in the west. But we haven't updated it in a little bit, but I can send it to Deshay. And that way, if any of you wanted to reach out to some of those other counties who are doing the treatment and for any consultation or questions, you'd have that contact information. So I'll send it to you, Deshay.
I also have a something that I can attach along to. It's a resource guide that we've come up with as far as healthcare providers, FQHCs, needle exchange programs, all of that, all in one condensed sheet of paper. So just anything that helps. It may not apply to anybody, but you never know.
Yes, please send it, and I will happily update as necessary. But thank you both so much for coming and speaking with us today and giving us
Thank
all the
you.
information that we need
Thank you
about
so
how we
much.
can continue to address Hep C and COVID-19. Everyone enjoy your break, and we'll see you in 15 minutes.
Bye.
Bye. Thank you so much. Appreciate it.
Thank you so much for coming. I really enjoyed it.
First time doing one of these things, so.
You